Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 298 of our pharmacotherapy series, which majors in heart failure. The first question reads, CMG, a 49-year-old woman with a history of cardiomyopathy, with an ejection fraction of 25%, presents to the heart failure clinic with New York Heart Association Class 3 symptoms. She reports increased shortness of breath, chest pain, and fatigue. She has been optimized on drug therapy for 3 months. Her medications include metoprolol succinate 200 mg daily, furosemide 40 mg twice daily, lisinopril 20 mg daily, and spironolactone 25 mg daily. An ECG showed sinus rhythm at a rate of 72 beats per minute and a QRS duration of 144 milliseconds. Is she a candidate for cardiac resynchronization therapy? Approximately 1/3 of the patients with advanced systolic heart failure exhibit intraventricular or interventricular conduction delays that cause the ventricles to beat asynchronously. Ventricular dysynchrony is seen on ECG as a wide QRS complex with a left bundle branch block, and can lead to deleterious effects on cardiac function. Patients may present with reduced ejection fraction, decreased cardiac output, and presence of New York Heart Association Class 3 or 4 heart failure symptoms. These are all associated with increased mortality. Cardiac resynchronization therapy is the use of cardiac pacing to coordinate the contraction of the left and right ventricles. Initial randomized trials of cardiac resynchronization therapy show reduced heart failure symptoms and improved exercise tolerance and quality of life. The comparison of medical therapy, pacing, and defibrillator in heart failure, abbreviated as companion trial, enrolled 1,520 patients with New York Heart Association Class 2 or 4, with a QRS interval of at least 120 milliseconds, and left ventricular ejection fraction equal to or less than 35%, who were treated with optimal drug therapy, that is ACE inhibitors, diuretics, beta blockers, and spironolactone. Patients were randomly assigned to receive optimal drug therapy alone, optimal drug therapy and cardiac resynchronization therapy with a pacemaker, or optimal drug therapy and cardiac resynchronization therapy with implantable cardioverter defibrillator, abbreviated as CRTD. The primary endpoint was a composite of all-cause mortality and hospitalization. Both CRT and CRTD groups were associated with a decreased risk of primary endpoint compared with optimal drug therapy alone. All-cause mortality at 1 year was decreased by 24% in the CRT group, which did not reach statistical significance, and 43% in the CRTD group. The results of the cardiac resynchronization in heart failure study CARE-HF extended the findings of the companion trial. CARE-HF demonstrated a significant all-cause mortality reduction for cardiac resynchronization therapy pacing without defibrillator backup, that is cardiac resynchronization therapy, in patients with heart failure who received similar medical treatment. The inclusion criteria were New York Heart Association Class 3 or 4, ejection fraction of 35% or less, and QRS duration of 120 milliseconds or longer. The primary endpoint of all-cause deaths and hospitalizations for a cardiovascular reason occurred in fewer patients with cardiac resynchronization therapy compared with the optimal drug therapy, 39% versus 55%, with a p-value less than 0.001. Death or hospitalization for worsening heart failure was also significantly reduced with cardiac resynchronization therapy. The combined results of CARE-HF and Companion confirm the importance of CRT and CRTD in improving ventricular function, heart failure symptoms, and exercise tolerance, while also reducing frequency of heart failure hospitalizations and death. The role of cardiac resynchronization therapy in patients with mild heart failure symptoms, narrow QRS, chronic atrial fibrillation, and right bundle branch block, needs to be explored. According to the ACEI guidelines, patients with New York Heart Association Class 3 and ambulatory patients with Class 4 heart failure should receive cardiac resynchronization therapy, unless contraindicated, if they meet the following criteria. Left ventricular ejection fraction of 35% or less, presence of a wide QRS above 120 milliseconds, and receiving optimal heart failure standard medical therapy. Despite optimal doses of heart failure medications, CMB continues to have heart failure symptoms. Cardiac resynchronization therapy could provide incremental benefits beyond what is provided with drug therapy. The next question reads, if CMB presented with New York Heart Association Class 1 or 2 symptoms, would she be a candidate for cardiac resynchronization therapy? What is the evidence to support cardiac resynchronization therapy in New York Heart Association Class 1 and 2 patients? The CARE-HF and Companion trials provide strong evidence that cardiac resynchronization therapy induces reverse modeling in patients with symptomatic New York Heart Association Class 3 and ambulatory Class 4 heart failure. The next logical step was to evaluate the benefits of cardiac resynchronization therapy in heart failure patients with milder symptoms. The multi-center InSync ICD randomized clinical evaluation, abbreviated as the Miracle ICD-2 trial, randomized Class 2 through 4 heart failure patients but with separate specified endpoints for Class 2 patients. In this trial, patients with New York Heart Association Class 2 heart failure, a left ventricular ejection fraction of less than 35%, and a QRS of more than 130 milliseconds received a CRT-ICD device. Subjects were randomly assigned to active cardiac resynchronization therapy group (ICD) activated and CRT on, or control group (ICD) activated and CRT off. The primary endpoint was progression of heart failure, defined as all-cause mortality, hospitalizations for heart failure, and ventricular tachycardia or ventricular fibrillation requiring device intervention. A 15% reduction in heart failure progression was observed with active cardiac resynchronization therapy, but did not reach statistical significance. At 6 months, patients with active cardiac resynchronization therapy had improved exercise tolerance, but this was not significantly different from the control group. However, there was a significant decrease in ventricular end systolic volume and increased left ventricular ejection fraction after 6 months of therapy. Even though the study results did not translate into improved exercise tolerance, it helped to set the stage for future trials in patients with less symptomatic heart failure. The reverse trial enrolled 610 participants with New York Heart Association Class 1 or 2 heart failure, left ventricular ejection fraction less than 40%, and with a QRS duration of more than 120 milliseconds who received a cardiac resynchronization therapy device with or without implantable cardioverter defibrillator in combination with optimal drug therapy. The patients in the active cardiac resynchronization therapy group had significant improvement in left ventricular end systolic volume index, left ventricular end diastolic volume index, and left ventricular ejection fraction compared to control. The primary clinical endpoint, the percentage of patients with worsened clinical composite score, did not reach statistical significance at 12 months in patients enrolled in the United States, but in the European cohort a significant difference was seen at 24 months, primarily driven by the time to first hospitalization. The aggregate data from these two clinical trials provided overwhelming evidence that linked cardiac resynchronization therapy with substantial reverse remodeling in mild heart failure patients. The MAD-IT-CRT was the largest randomized trial designed to determine whether CRT-D therapy would reduce the primary endpoint, all-cause mortality or heart failure events, when compared with patients receiving ICD-only therapy. The study population involved cardiac patients in New York Heart Association functional Class 1 or 2 with left ventricular ejection fraction of 30% or less and QRS duration of more than 130 milliseconds. There was a 34% with a p-value less than 0.001 reduction in the primary endpoint, and a 44% with a p-value less than 0.001 reduction in heart failure events when compared with implantable cardioverter defibrillator therapy. Patients with CRT-D therapy showed an 11% improvement in left ventricular ejection fraction after 1 year, compared with 3% improvement for ICD-alone patients. Both MAD-IT-CRT and reverse excluded patients with atrial fibrillation. Both studies failed to show a benefit for cardiac resynchronization therapy in patients with QRS duration less than 150 milliseconds. The resynchronization, defibrillation for ambulatory heart failure trial, abbreviated as RAFT, confirmed that cardiac resynchronization therapy benefited patients with a QRS duration of 150 milliseconds or more and in those with left bundle branch block. The RAFT investigators randomly assigned 1,798 patients with New York Heart Association Class 2 or 3 heart failure, left ventricular ejection fraction of 30% or less, and a QRS duration of at least 120 milliseconds, or a paced QRS of at least 200 milliseconds, to either implantable cardioverter defibrillator therapy alone or an implantable cardioverter defibrillator with cardiac resynchronization therapy, abbreviated as CRT-D. The primary outcome was a combination of total mortality and heart failure hospitalization, which was significantly higher in the implantable cardioverter defibrillator group compared with the ICD-CRT group, 40% versus 33%, respectively. These findings demonstrate that earlier intervention with CRT-D, in addition to guideline-recommended medical and implantable cardioverter defibrillator therapy, benefits this patient population. The next question reads, TDF, a 72-year-old white woman, has a 5-year history of heart failure symptoms, including decreased exercise capacity, shortness of breath, and distended neck veins. She has minimal peripheral edema. History is suggestive of rheumatic fever as a child, but she does not recall having any cardiac symptoms when she was younger, other than being told she had a murmur. Her symptoms are controlled with diuretics. she has hypertension but no other medical problems, and all laboratory test findings are normal. Her BP is 155 systolic, 85 diastolic. Her heart rate is 90 beats per minute. Cardiac examination reveals a prominent S4 heart sound. Echocardiography reveals an ejection fraction of 50%. Prior treatment included furosemide, most recently at 40 mg twice daily. The physician is considering adding a beta blocker or calcium channel blocker to control the BP and heart rate. Why might this consideration be appropriate? This case exemplifies a patient with heart failure with preserved left ventricular ejection fraction, abbreviated as half-PEF, previously referred to as diastolic heart failure. Risk factors for heart failure with preserved left ventricular ejection fraction include advanced age, female sex, hypertension, and coronary artery disease. This diagnosis can be made on the basis of left ventricular hypertrophy, clinical evidence of heart failure, a normal ejection fraction, and echocardiography findings. The ideal treatment for heart failure with preserved left ventricular ejection fraction has not been extensively validated. No drug selectively enhances myocardial relaxation without having associated effects on left ventricular contractility or on the peripheral vasculature. Factors affecting heart failure control, such as adherence to medication and diet, including NSAID and herbal remedy use, should be appropriately managed along with drug therapy. Symptomatic heart failure with preserved left ventricular ejection fraction is initially treated similar to other forms of heart failure, by slow diuresis. Diuresis decreases preload and lessens passive congestion of the ventricles. Excessive lowering of ventricular filling pressures, however, can decrease cardiac output and cause hypotension. The most common cause of heart failure with preserved left ventricular ejection fraction is hypertension that leads to left ventricular hypertrophy and decreased cardiac compliance. The ACEIs, AHA, HFSA guidelines recommend a systolic blood pressure goal of below 130 mm of mercury in patients with heart failure with preserved left ventricular ejection fraction and persistent hypertension after management of fluid overload. Drugs that cause regression of left ventricular hypertrophy, e.g., ACE inhibitors, angiotensin II receptor blockers, or beta blockers, may also slow or reverse structural abnormalities associated with heart failure with preserved left ventricular ejection fraction. In the perindopril in elderly patients with chronic HF, abbreviated as PEP-CHF, trial, the ACE inhibitor perindopril failed to reduce the incidence of the primary endpoint, all-cause mortality or heart failure hospitalizations, but did reduce symptoms and improved functional capacity. The CHARM-preserved trial also failed to show any difference in cardiovascular mortality, but fewer hospitalizations were seen in the candesartan group. The valsartan in diastolic dysfunction, abbreviated as VALID trial, compared the effects of valsartan or placebo added to standard antihypertensive therapy, which included diuretics, beta blockers, calcium channel blockers, or alpha blockers, in patients with mild hypertension and diastolic dysfunction. The hypothesis of this trial was that renin-angiotensin-aldosterone system inhibition with an angiotensin II receptor blocker would be associated with greater improvement in diastolic function, due to more regression of left ventricular hypertrophy or myocardial fibrosis. Patients with a history of stage 1 or 2 essential hypertension were randomly assigned to receive either valsartan 160 mg, titrated up to 320 mg, or matching placebo. Patients who did not achieve a target BP goal of less than 135 systolic 80 diastolic received additional therapy, starting with a diuretic followed by a calcium channel blocker or a beta blocker, then an alpha blocker. Angiotensin II receptor blockers, ACE inhibitors, and aldosterone blockers were excluded. The primary endpoint was the change in diastolic myocardial relaxation velocity from baseline to 9 months, with a secondary endpoint of change in left ventricular mass. During the study, the placebo group received more concomitant antihypertensive therapy compared with the valsartan group. A small, but significant, increase was seen in diastolic relaxation velocity in both groups from baseline to follow-up, but there was no significant difference between the treatment groups. BP reduction did not differ significantly between the two treatment groups, and was associated with significant improvement in diastolic function. The authors concluded that aggressive BP control, even in mild hypertension, was associated with improvement in diastolic dysfunction, irrespective of whether BP reduction was achieved with a renin-angiotensin-aldosterone system inhibitor or other antihypertensive agent. Charm Preserved investigated the role of candesartan in patients with HFpEF. The trial enrolled 3,023 subjects who met the overall CHARM trial inclusion criteria with an ejection fraction of more than 40%, with a mean of 54%. Subjects had symptomatic heart failure with normal preserved ejection fraction. They received either an angiotensin II receptor blocker alone N equals 1514 or placebo. Only 20% of subjects in both groups were taking an ACE inhibitor at randomization, 56% a beta blocker, and 11% spironolactone. After a median follow-up of 36.6 months, a trend was noted toward reduction in the primary outcome of cardiovascular death or hospital admission for heart failure in the candesartan group, that is 22%, compared with placebo, that is 24.3%, with a p-value equal to 0.118. Cardiovascular deaths and all-cause mortality were nearly identical in both groups, but the total number of hospitalizations for heart failure was significantly reduced in the candesartan group. The most common side effects with candesartan were hypotension, that is 2.4%, increase in creatinine, that is 4.8%, and hyperkalemia, that is 1.5%. Discontinuation because of an adverse event occurred in 17.8% of those treated with candesartan compared with 13.5% of placebo recipients, with a p-value equal to 0.001. Overall, in symptomatic patients with HFpEF, no significant improvement in mortality occurs with candesartan compared with placebo, but there was a significant reduction in heart failure-related hospitalizations. The I-PRESERVE trial evaluated irbesartan titrated to 300 mg daily or placebo for the management of HFpEF. The patient population was 60 years of age or older with New York Heart Association Class 2 through 4 symptoms, ejection fraction of at least 45%, and hospitalized for heart failure within 6 months prior, or have persistent Class 3 or 4 symptoms N equals 4128. There was no difference in the primary endpoint, death from any cause or hospitalization for a cardiovascular cause, between irbesartan, that is 36%, and placebo, that is 37%. The irbesartan group had more patients experiencing hyperkalemia than placebo. One possible reason for the neutral results of the I-PRESERVE trial included the high rate of dual renin-angiotensin-aldosterone system blockade at baseline, 39% ACE inhibitor use in the irbesartan group and 40% in the placebo group, 28% spironolactone use in the irbesartan group and 29% in the placebo group. Based on this high use, the study is less likely to find benefit with angiotensin II receptor blockers in addition to other renin-angiotensin-aldosterone system agents. Another potential limitation of the study included the high study discontinuation rate, that is 34%. Overall, irbesartan showed no benefit in reducing morbidity or mortality in HFpEF patients. Beta blockers or non-dihydropyridine calcium channel blockers are other classes of drugs of interest in HFpEF. Part of their value is to control hypertension, a risk factor for all forms of heart failure. More specific to HFpEF, beta blockers and calcium channel blockers, especially verapamil, possess negative inotropic properties that may favorably influence the pathophysiology of diastolic dysfunction by a. slowing the heart rate to allow more time for complete ventricular filling, particularly during exercise, b. reducing myocardial oxygen demand, and c. controlling BP. Both pharmacologic classes are beneficial in decreasing ischemia in patients with coronary artery disease. Most heart failure trials with beta blockers demonstrating decreased morbidity and mortality have focused on HFrEF. The study of the effects of nebivolol intervention on outcomes and rehospitalization in seniors with heart failure, abbreviated as SENIORS study, evaluated beta blocker use in elderly heart failure patients irrespective of left ventricular function. The trial randomly assigned patients to nebivolol or placebo. Nebivolol is a selective beta-1 adrenergic receptor blocker with vasodilator properties that are mediated through nitric oxide release. This effect may be beneficial in elderly patients who tend to have low reserves of endothelial vasodilation. The primary endpoint of the study was the combination of all-cause mortality and CV hospital admissions. The endpoint was significantly reduced by 14% in the nebivolol group, regardless of the ejection fraction. Prospective subgroup analyses of the primary outcome by left ventricular ejection fraction equal to or less than 35% or above 35%, sex or age equal to or less than 75 years or above 75 years showed benefits across all subgroups. Patients with ejection fraction greater than 35%, however, appeared to benefit a little more than those with low ejection fraction percent, and all-cause mortality was lower in patients older than 75 years treated with nebivolol compared with placebo. The study reinforces the current recommendations that all heart failure patients with reduced ejection fraction should receive beta blockers. Only 35% of the patients had preserved left ventricular function, and were mostly men. This is not typical of patients with HFpEF, who are frequently women. Further studies are required to define the role of beta blockers in HFpEF. No randomized controlled trials have demonstrated mortality benefits with calcium channel blockers in HFpEF. Non-dihydropyridine calcium channel blockers can be used in patients who have a contraindication to beta blockers to control BP and heart rate. Non-dihydropyridine calcium channel blockers should not be used in patients with HFrEF. The role of aldosterone antagonists in the management of patients with HFpEF has been evaluated in the treatment of preserved cardiac function heart failure with an aldosterone antagonist (TOPCAT) trial. This trial evaluated the impact of spironolactone versus placebo on cardiovascular morbidity and mortality in patients older than 50 years of age with an ejection fraction greater than 45%. There was no difference in the primary endpoint composite of cardiovascular death, aborted cardiac arrest, and hospitalization for heart failure between the spironolactone and placebo treatment arms, with a hazard ratio of 0.89, with a 95% confidence interval of 0.77 to 1.04, with a p-value equal to 0.14. There was a significant reduction with spironolactone versus placebo in the secondary endpoint of hospitalization for heart failure with a hazard ratio of 0.83 with a 95% confidence interval of 0.69 to 0.99, with a p-value equal to 0.04. There has also been a sub-analysis of the TOPCAT study evaluating differences in patients enrolled in the Americas compared to Russia, Georgia relative to the primary and secondary endpoints. When only looking at patients enrolled from North or South America, there was a significant reduction with the spironolactone-treated patients compared to placebo in the primary endpoint, with a hazard ratio of 0.82 with a 95% confidence interval of 0.69 to 0.98, and all secondary endpoints. Based on these findings, the 2017 ACEI/HFSA focused update recommend aldosterone receptor antagonists class 2B in HFrEF. An aldosterone receptor antagonist can be considered to decrease hospitalizations in patients with ejection fraction equal to or more than 45%, an elevated B-type natriuretic peptide, or recent hospitalizations. If spironolactone is initiated, then potassium and renal function should be closely monitored, e.g. FR above 30 ml per minute, creatinine 2.5 mg per deciliter, potassium less than 5.0 milliequivalents per liter. TDF fulfills the criteria for having HFpEF, based on her history of long-standing hypertension, which has been poorly controlled. Her BP is not at goal, and her heart rate is elevated. Therefore, antihypertensive therapy is warranted. Tachycardia alone can compromise the ventricle filling time and cause myocardial ischemia. So far, no data support the use of one agent over another. Beta blockers and non-dihydropyridine calcium channel blockers can each reduce BP and heart rate. Beta blockers are not considered first-line antihypertensive medications based on recent guidelines without a compelling indication. The use of a non-dihydropyridine CCB would be supported in HFpEF patients to reduce both BP and heart rate. TDF can be started on a non-dihydropyridine calcium channel blocker such as diltiazem sustained release, dosed at 120 mg daily. The next question reads, PWL, a 60-year-old man recently diagnosed by his naturopath with heart failure, is concerned about his decreasing exercise capacity and increasing shortness of breath during his morning walks. The naturopath wants to initiate hawthorn and coenzyme Q10 to control his heart failure symptoms. The patient has uncontrolled hypertension with a BP of 170 systolic 85 diastolic, and has 2+ ankle edema. He distrusts medical doctors because in the past he was given hydrochlorothiazide for BP reduction, but stopped taking it after a few days because he did not tolerate the urinary urgency it caused. What is the role of herbal products and nutritional supplements in heart failure? We will begin with hawthorn. Hawthorn extracts from the leaves and flowers of Crataegus monogena and Crataegus oxyacantha have been reported to have beneficial effects in mild heart failure. Oligomeric procyanidins and flavonoids are considered the key active ingredients. Hawthorn extracts have shown positive inotropic effects, weak ACE inhibition, vasodilating properties, and increased coronary blood flow in vitro and in animal models. In short-term 8 weeks or less, placebo-controlled trials in patients with the equivalent of New York Heart Association Class II heart failure, modest improvements were noted in exercise tolerance and subjective symptoms as well as decreases in HR and BP. Patients with more advanced heart failure were excluded. A systematic review by Pitler et al. Also concluded that hawthorn extract was efficacious in the treatment of heart failure when given with standard heart failure therapy. Conversely, the results of the hawthorn extract randomized blinded chronic heart failure abbreviated as HERB-CHF trial failed to provide any evidence that hawthorn was beneficial in patients with heart failure who were already receiving standard medical therapy. In clinical trials, side effects of hawthorn include nausea, vomiting, diarrhea, palpitations, chest pain, and vertigo. These side effects are more common when doses exceed 900 mg per day, but in some trials they have not occurred more often than with placebo. The risks and benefits of using hawthorn and digoxin together, both of which have positive inotropic effects, are not known. To further investigate the longer-term benefits of hawthorn, additive effects to conventional therapy and effect on mortality were tested in the survival and prognosis investigation of Crataegus extract, WS 1442 in congestive heart failure called the SPICE trial. The trial enrolled 2,681 patients with New York Heart Association Class II or III, left ventricular ejection fraction of 35% or less, who were randomly assigned to hawthorn or placebo for 2 years. Although the study failed to show any clear benefits in the treatment of chronic heart failure, hawthorn was well tolerated. Next we will look at coenzyme Q. Coenzyme Q, also known as ubiquinone and ubidicarinone, is an endogenously synthesized provitamin that is structurally similar to vitamin E, serves as a lipid-soluble electron transport carrier in mitochondria, and aids in the synthesis of adenosine triphosphate. It may also have membrane-stabilizing properties, enhance the antioxidant effects of vitamin E, and stabilize calcium-dependent slow channels. In animal models, it has positive inotropic effects, although weaker than those of digoxin. More than 18 open-label and double-blind, randomized clinical trials have been conducted of coenzyme Q in patients with heart failure ranging from New York Heart Association classes 2 to 4. Doses varied from 50 to 200 mg per day. Patients in many of these trials were also taking diuretics, ACE inhibitors, and digoxin. Different trials used different endpoint measurements. Positive effects on subjective symptoms, New York Heart Association class improvement, ejection fraction, quality of life, and hospitalization rates have all been observed. 2 trials, however, failed to demonstrate significant changes in ejection fraction, vascular resistance, or exercise tolerance. None of the trials had sufficiently large sample sizes or adequate duration of assessment to detect reduction in mortality. Side effects were minimal, but included nausea, epigastric pain, diarrhea, heartburn, and appetite suppression. Mild increases in lactate dehydrogenase and hepatic enzymes have been rarely reported with coenzyme Q doses in excess of 300 mg per day. Because no clinical trials have demonstrated improved survival with nutritional, herbal supplements, the current guidelines do not recommend these agents in patients with current or prior symptoms of HFrEF. PWL has poorly controlled systolic hypertension and heart failure that is beginning to interfere with his activities of daily life. Although evidence indicates that patients with New York Heart Association Class II heart failure obtain symptomatic improvement with hawthorn and coenzyme Q, this does not address PWL's hypertension. Conflicting data exist on the value of coenzyme Q in lowering BP. The results of the SPICE trial did not demonstrate any mortality benefits, and no incremental benefits were seen when combined with standard therapy. Uncontrolled hypertension in patients with heart failure leads to cardiac remodeling, and worsening heart failure. Currently PWL is presenting with symptomatic heart failure, therefore, he should be started on a diuretic to alleviate his symptoms. Starting with a 20 mg dose of furosemide and titrating slowly may be one approach. For all of the reasons cited throughout this chapter, one must also argue strongly for starting an ACE inhibitor to control his hypertension. He should be counseled that the urinary frequency he experienced previously should diminish after a few days. Once he is euvolemic, a beta blocker should be started. The guidelines clearly state that natural products should not be used to treat symptomatic heart failure. Agents such as ephedra, which contain catecholamines, ephedrine metabolites, or imported Chinese herbs are contraindicated in heart failure because of increased risk of mortality and morbidity. No regulatory oversight, quality control, or regulations exist on the use of natural supplements. Because of the widespread use of nutritional supplements and herbal therapies and their potential to cause drug interactions, clinicians should routinely inquire about their use. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 299.